Hello, Assalamu alaikum, and thank you for joining us on a Sunday afternoon. I am Tehmina Munaf. I'm a family physician in Lethbridge, and I welcome you all to the second annual Health Symposium organized by Appna Alberta Chapter. We will also be live on our Facebook page, Appna Alberta Chapter. Appna is an association of Pakistani physicians in North America. Appna has been working successfully for almost over 40 years in North America and is growing across Western Canada. Appna Alberta Chapter has been working very efficiently alongside for the past 2 years. And thanks to strong leadership and advocacy in Canada, that has made Appna strong. Our program will include messages from team leads from our Western Canadian provinces. We also have a special note from Pakistani Consulate General, and we have 2 great speakers with us who will be discussing very relevant topics. Our team lead messages from Western Canadian provinces focus on advocacy, healthcare, collaboration, and education. Today's event sponsors are Canada Diagnostics. I would like to thank you, Canada Diagnostic Centres, for sponsoring our event. Before we move on, I would like to begin with welcoming Dr. Khurshid Khan. Dr. Khan is a neurologist with subspecialty fellowship training in cerebrovascular disorders. He's currently appointed as Professor of Neurology in the Faculty of Medicine, University of Alberta. Dr. Khan is a Director of Stroke Fellowship Program, one of the largest stroke fellowship programs in Canada. Dr. Khan also served as the Director of the Adult Neurology Residency Program. In addition to his busy clinical work, he's actively involved with education, and his research interest involves cerebral flow dynamics using ultrasound. Let's hear from Dr. Khan.
Thank you, Dr. Munaf. Assalamu alaikum and good afternoon. On behalf of Alberta chapter of Appna, it's a pleasure to welcome all the participants. Consul General of Pakistan, Mr. Janbaz Khan in Vancouver, and our esteemed guest speakers, Dr. Hanan Besoni and Dr. Sanjeev Chopra, to this health symposium. Since its inception, Alberta Appna has organized various health awareness and social support activities. However, the unique feature of this second health symposium is that this is a joint effort of our colleagues in Manitoba, led by Dr. Mubin Rafi, in Saskatchewan by Dr. Najma Jamil, and in British Columbia, spearheaded by Dr. Barbara Rana and Dr. Faisal Khosa. As some of you already know, that Appna is a nonprofit organization which was established, as Dr. Munaf said, more than 40 years ago and has a large membership. The founding elders envisioned Appna to provide a platform for scientific development and education in medicine, as well as community service in Pakistan and in North America. There is a tremendous sense of enthusiasm among physicians of Pakistani origin in the Western provinces of Canada to collaborate and promote the mission of Appna. Alberta chapter of Appna was established not too long ago, but the leadership of Dr. Tariq Awan, Dr. Samina Bajwa, Dr. Saad Yassin, Dr. Hussam Bawa, Dr. Kamran, and Dr. Yasmin Majid has been working tirelessly to realize its full potential. Their excitement also tapped into the never diminishing energy of Dr. Shoaib, a colleague, neurologist and professor of medicine at the University of Alberta, who has further helped galvanize many physicians of Pakistani origin across Western Canada. We believe that with selfless efforts and collaboration, we all can contribute immensely to the mission of Appna. Today we have an excellent program, and at the end, I once again welcome you all and wish you an enjoyable listening to these two excellent speakers this afternoon. Thank you and Assalamu alaikum.
Thank you, Dr. Khan, for acknowledging all the hard work of physicians who made Appna possible in Canada. Now we have with us a video message from Dr. Tariq Ivan. Dr. Ivan is a family physician in Calgary since 2004. He is a fellow College of Family Physicians of Canada. Dr. Ivan is a teacher and preceptor at Cummings School of Medicine, University of Calgary. He is founding president of Appna Alberta chapter. He is also chair for Team Shaukat Khanna Memorial Cancer Hospital and Research Center in Calgary since 2018. Dr. Ivan is married, has 2 boys. He loves watching and playing sports and enjoys family time. Let's listen to Dr. Ivan.
Assalamu alaikum and hello everyone. I am Tariq Ivan. Welcome to Alberta, the wild rose country. Primarily known for its oil and gas, also famous for its rocky mountains, cold winter and excellent skiing. Alberta hosts the greatest outdoor show on earth, the Calgary Stampede. At Appna, we strive for recognition, unity, equality, and empowerment of Pakistani decent physicians across North America. We stand together to safeguard the interests of Pakistani Canadian physicians who are actively supporting the best healthcare system in the world. Through our strong advocacy, Appna is providing the resources and information available to its physicians to build their knowledge and enhance their patient care. Also supporting the international medical graduates of Pakistani descent to integrate in the local healthcare system so that they can play their important role in serving the local communities and Pakistan. Thank you.
Thank you, Dr. Ivan. Alberta is indeed a beautiful province. Now I'm excited to tell everyone that we're joined today by Mr. Jambaz Khan. He is Consulate General of Pakistan in Vancouver for Western Canada. He has also served in Turkey, India, and Germany. He also served as the Deputy Head of Mission in France and Deputy High Commissioner in Sri Lanka. Thank you for taking the time to join us, sir.
Assalamu alaikum, and thank you very much for this kind invitation. I felicitate Dr. I would like to take this opportunity to thank Dr. Babra to invite me to this August gathering. My personal felicitations to all of you. You are doing a brilliant job. I've heard your president's message. That is the core and the crux of your organization. And for your information, I would be replicating this thing not only for, like you doctors are doing it, but for engineers as well, for businessmen as well, for computer experts as well. There should be associations in Northern America of these other groups also, so that primarily should concentrate on incoming Pakistanis to North America to be integrated in the system. I have been affiliated with the noble profession of doctors for a bit of a long time because I'm married to one as well. That's the present part of the life. I don't need to go to any other doctor. I am taken care of at home. But that said and done, as Deputy High Commissioner, when I was in Sri Lanka, I saw your organization work, how it got the corneas from North America and took them to Pakistan, how it helped people there. I was truly impressed. My warmest regards, my best of wishes, and please do understand, in Western Canada, the Consulate General of Pakistan is in Vancouver, is at your service. For Pakistanis as well as for Pakistan. Please feel free to approach me. You don't need any PA or any staff to come to me. We are available on Park in Vancouver, on Instagram, on Twitter, on Facebook. My personal email is on the website. Any help, any support, anything this August organization wants, I'm at your service. The Consulate General is at your service. Once again, my heartfelt felicitations and my best of luck to all of you for doing such a brilliant and outstanding work of which all of us are proud of. Thank you very much, Ms. Munaf, for this kind introduction.
Thank you so much, Mr. Jambaz Khan, for your kind words and offering us your support. Now we have with us a video message from Saskatchewan's team lead, Dr. Najma Jamil. Dr. Jamil graduated from King Edward Medical College and moved to Edmonton right after that. She did her master's in pediatric immunology and then fellowship in cross cancer. She moved to Saskatchewan and has been practicing as a family physician with obstetrics. She enjoys traveling, camping, hiking, and sports to this day. She was an athlete throughout her school days. Let's hear from Dr. Jamil.
Assalamu alaikum and hello everybody. I'm Najma Jamil, representing Saskatoon in Saskatchewan. I moved here in 1993 from Edmonton and I've loved the place since the day I came. Saskatchewan is the birthplace of healthcare system in Canada. I'm proud to maintain this tradition in Appna, Association of Pakistani Physicians in North America. Our utmost priority is to provide world-class healthcare in both general and subspecialty medicine. And we have an excellent team of physicians serving all communities in North America and overseas.
Thank you, Dr. Jamil. Now it's time to move on to our first topic of today's discussion, which is benefits of fasting and managing chronic disease. To discuss this, we have invited Dr. Hanan Basuni to share her vast knowledge on this subject with us. Dr. Basuni is a medical director, fellow of Royal College of Physicians and Surgeons of Canada. She is a clinical associate professor of medicine at Cummings School of Medicine, University of Calgary. She provides a general endocrinology and diabetes in pregnancy care across Calgary. She also provides consultation services to underprivileged and refugee population through the Alex and the CUPS in Calgary. Academia is a deep passion for her, so she is deeply involved at Cummings School of Medicine, chairing the endocrinology and communication courses and teaching across undergrads and postgraduate medical curricula. She has won multiple teaching awards locally in Calgary, as well as Distinguished Taylor Institute Award in 2018, and nationally the Canadian Association for Medical Education Certificates of Merit Award in 2017. Thank you for joining us, Dr. Basuni.
Thank you very much, Dr. Manaf. I appreciate your kind introduction. Can you hear me okay?
Yeah, we can hear you. Go ahead.
Thank you. Assalamu alaikum, everybody. It's really a pleasure for me to be a part of this. I am not of Pakistani descent, but I certainly work with lots of wonderful Pakistani physicians in Calgary, where I live and practice. So it's a great honor to be here today. I wanted to start off by just telling you a little bit about myself, that I do practice endocrinology here. I've been doing so since 2005, and I work mostly with Alberta Health Services at the Peter Lougheed Hospital in the Foothills, and I have a diabetes and pregnancy clinic as well at the Foothills. I also do outreach clinics to the Alex, where there's disadvantaged and underprivileged populations and vulnerable populations, so seniors, addictions, youth, pregnancy, indigenous, and so on. It has been a great honor to be a part of the healthcare system here in so many capacities. I also take a lot of pride in my job as a teacher, because I believe that teaching students to be good human beings is probably the most important job that we have as physicians, regardless of where we come from or where our journey started. To start with, I just wanted to share that I really don't have any disclosures in terms of funding. I don't receive any grants or anything like that, or funds from any pharma. So just wanted to say that. And I also want to disclose that what I'm going to present today is really based on Diabetes Canada guidelines, as well as my anecdotal experience of 15 years. And things have changed quite a bit in diabetes management over the course of the last 2 decades, with new agents and so on, and also our understanding of the disease. So as you all know, we are just now, the middle of Shaban is actually today. And so we all did our prayers last night for the middle of Shaban night, which is a very special night. And Ramadan is just around the corner. So it's a very exciting time, but often a time that our patients will reach out to us to ask, am I safe to fast? I really want to. Most people take pride in doing this pillar of Islam and want to carry through with it. So it is our job as physicians to help them individualize their plans to what is safe for them, but also to what is culturally and religiously sensitive for them, because this is a huge part of our identity as Muslims. So my objectives are here, and please don't be alarmed by how many there are. It's not going to be a very long talk, but I just wanted to break it down into patient objectives and educator or doctor objectives. So the first group here will be the patient objectives. Does everyone have to fast? Is it okay for me to fast even if I have diabetes? What are the risks that I should be aware of if I do fast? Is fasting harmful when a woman is expecting a baby? What about breastfeeding? How is low blood sugar treated during the fast? Will testing my sugars or treating a low sugar break my fast? Do I stop taking diabetes medicine during Ramadan? How often should I be testing my sugars? So those are all questions that we're going to touch on, and I welcome more questions, of course, at the end. From a doctor perspective, you're going to be asked, what are the contraindications to fasting? When is it okay to fast? When is it not safe to fast? What about oral agents or non-insulin agents? What about insulin? What regimen is the optimal one? And what dose adjustments might need to be made? And how do we educate our patients regarding this and giving them some flexibility so that they don't feel cornered into one way of thinking or doing? And then, of course, post-Ramadan follow-up. So as everybody knows, probably who's attending here, Ramadan entails abstaining from eating and drinking from pre-dawn to sunset. And this occurs for roughly 30 days, depending on the lunar calendar. There's usually 2 main meals. And the reason I say usually is because some people graze all the time between sunset and sunrise the next day. But typically there is a small meal in the morning before sunrise. And then there's a larger meal, that's the main meal of the day, which is iftar at sunset. So what happens when we fast normally? Like if we're just thinking about, when you stop eating for a while, what happens? Well, your glucose levels in the blood will drop, and that's expected. And therefore, the response to that is that your body will shut down insulin in order to prevent that from going even lower. At the same time, there's other hormones that will go up, including the counter-regulatory hormones. So things like glucagon and adrenaline, they will go up in order to maintain that balance of sugars. And that occurs by breaking down stores of glycogen into glucose. As the fasting state prolongs, now the low insulin levels will be interpreted as a little bit of a threat, because your fatty acids are now going to be metabolized as an alternate source of energy. Normally, your body relies on glucose, but now that you don't have glucose, that now your body kind of goes into mode, kind of plan B, which is to break down fatty acids. And that comes from fat tissue or adipocytes. And as that happens, then ketones accumulate. So all of us are going to have ketones after not eating for a few hours. And the longer we are not eating, the more ketones will be in the blood. So you can immediately kind of recognize why this might be an issue, especially in patients with type 1 diabetes, because in type 1 diabetes, the presence of ketones is actually a marker that something could be wrong. And we always ask our patients to check frequently for their blood and urine whether they have ketones. And if they do, they have to take a little bit more insulin. They have to be more careful. They have to make sure they're not going into diabetic ketoacidosis, which is a life-threatening condition. And so that is one of the reasons that really people with type 1 diabetes are especially disadvantaged and really need to think hard about whether they are okay to fast or not. Whereas in type 2 diabetes or anybody who has prediabetes or other conditions where you're just fasting and you have ketones, it's okay. You know why you have ketones, it's because you haven't eaten. But in type 1 diabetes, it could be because you're not eating, but also because you don't have enough insulin. And the two things can be very dangerous as a combination. So what are the risks of fasting in diabetes? Well, obviously hypoglycemia, but also hyperglycemia, because if you're afraid to take insulin, your sugars might go high, and then that can also result in an osmotic diuresis, because when your sugars go high, your kidneys want to clear some of that sugar, and then you become dehydrated because it pulls water with it. So you can have a diuresis or an osmotic loss of water with the glucose. You can also have diabetic ketoacidosis as a complication if you don't have enough insulin on board. And you can have dehydration, and the dehydration can result in blood viscosity, which can cause thrombosis or even TIAs or strokes. So in general, as a general rule, Muslims are exempt from fasting if they have diabetes, but it is an individual decision. And I don't think we can make a blanket statement to say you have to fast or you have to not fast. I think it's a case-on-case decision that needs to be made. Dr. Manaf, I'm just going to say that I noticed there are some chats in the chat box, but I'm not going to do that right now. So I'm going to leave it up to you to please follow up on that. Okay, I'm going to just follow on with my presentation if that's okay.
For sure. I just want to remind the audience, if they have any questions, you can post them in the chat box. And once Dr. Basuni is done with her presentation, we'll go ahead and answer those questions for you guys. Thank you.
Thank you very much. So I think as physicians, when we are approached by our patients, and hopefully this will happen one to 2 months before Ramadan, not the day before Ramadan, to have a plan, you want to categorize your patient into either a high risk, a moderate risk, or a low risk category. And this actually has been done in the Diabetes Canada, most recent Diabetes Canada guidelines here, that they break them down into very high risk patients who must not fast, ones that are intermediate, they should not fast, and then ones that are low or moderate, and then you can fast with medical advice and with a plan in place. So let's kind of zoom in on each one of those. So when we look at the very high risk category, who must not fast? Must not fast. Well, those would be people with poorly controlled type 1 diabetes with an A1C of over 9%, people who have severe hypoglycemia in the last few months or are unaware of their lows, meaning that they have lows but they don't feel them. That can be very dangerous because those people are at risk for seizures and coma, obviously a life-threatening condition. If somebody has had diabetic ketoacidosis within 3 months of Ramadan, that's probably a reason to not fast. If they've had hyperosmolar hypoglycemic coma, that's a type 2 diabetes medical emergency. Also, they should probably not fast. Anybody with an acute illness who has diabetes, for example, somebody comes down with a pneumonia or a bladder infection or a pyelonephritis, some kind of acute illness that requires hospitalization or acute treatment, probably they should break their fast for those days. If they have advanced macrovascular complications, including heart attacks in the recent past, including cognitive dysfunction, renal disease, especially stage 4 and 5 CKD, and people who are on dialysis, uncontrolled epilepsy. Pregnancy is another point that we used to list as an absolute, we can't fast, but again, it's open for discussion, but we will talk about specifically pregnancy a little bit later. And of course, if a woman is treated with insulin, that makes it trickier to fast than if she was treated with metformin or just on diet control. Those are categories of people who must not fast. What about intermediate risk things? So people who should not fast. Those are still considered intermediate to high risk. So people with type 2 diabetes with sustained poor glycemic control, again, over 9%. Again, because of the risk of osmotic diuresis and dehydration. People who are well controlled with type 2, but they have multiple insulin injections, likely 4 times a day. Again, it just makes it tricky. It's not impossible, but it makes it tricky to do this safely. Women who are pregnant with type 2 or gestational, controlled by diet only. Again, open to discussion, but there is a risk, and we'll talk about that shortly. People with chronic kidney disease stage 3 or stable macrovascular complications. People who are performing intense physical labor, especially in very hot weather, who are going to get dehydrated very easily. That could be a concern. A patient with type 1 diabetes, again, even if they're well controlled and their A1C is where it needs to be, remember the issue with ketones and being unable to interpret what is causing the ketosis. So type 1 diabetes is a very humbling condition, and then you throw fasting on top of it, and it becomes very, very humbling. So really, I'm very respectful that people want to fast, but type 1 diabetes makes me nervous in fasting for sure. Having said that, I have had patients who have managed to fast successfully with type 1. Then we're talking about moderate to low risk. So people who can fast with medical advice. So those are people who are well controlled, probably with lifestyle alone or with oral agents or non-insulin agents, I should say, because now there's injectables that are not insulin. So people on metformin, acarbose, incretin-based therapy such as DPP-4 inhibitors and GLP-1 receptor agonists, sulfonylureas, Sglt2 inhibitors, TZDs, and so on. Or people with just prediabetes who are on diet control. Those probably are people who would benefit from fasting. So let's start with type 1. Again, in type 1 diabetes, really you want to assess what kind of insulin the patient is on. You want to probably consider switching them from an intermediate. What we mean by intermediate is Novolin NPH and Humulin N, because those ones really do peak. So you want to be very careful that peak, if they take that dose in the morning, they will peak midday when they're fasting, and that can result in hypoglycemia. In fact, if people are on a pump, it actually is easier to fast. And I'm not saying that everybody on a pump should fast. I'm not saying that at all. But what I'm saying is, if you think about it in a pump situation, patients are getting minute-to-minute basal insulin, and that will allow them to have control of suspending the pump or, holding back or cutting back a little bit. Of course, that can also be dangerous because if you hold the pump for so long, they can go into diabetic ketoacidosis, and then you can have euglycemic Dka, which is not good either. What euglycemic Dka is when you have a situation where you're not able to produce hyperglycemia, maybe because of poor reserve, because of fasting, because of malnutrition. For a variety of reasons, people don't have to have high sugars to have DKA, and that makes it especially tricky. But if you're going to choose somebody to be able to fast in Ramadan and do it safely, being on a pump is actually, kind of conducive to success because it gives you that minute-to-minute control as opposed to taking one shot of a basal insulin once a day and you're stuck with it for the 24 hours. If somebody goes low with that, you have to break your fast. There's no other way about it. Okay. So type 1 diabetes is very tricky, and I've had patients who usually takes them 3 or 4 days that they have to figure things out, and then they cut back on their insulin, and then they are able to finish the month. But it takes a few days or even a week to get there. And those are usually people who are not pregnant. If they're pregnant, I really discourage people with type 1 diabetes from fasting. With type 2 diabetes, again, talking to the patient, assessing your goals, assessing where they're at, and also just going into details on how they eat in Ramadan. People are very different culturally, and every culture has its own way. Some people just have strictly the 2 meals. Some people only eat 1 meal. Some people graze all night. So you really need to go into more detail about how they do Ramadan. So now I want to go through each one of the drugs and go over the safety of these medications during fasting. So metformin is the first one, and metformin is really safe. I would say that is an agent that you can easily continue. You might just want to modify the dose so that instead of taking it BID or TID, so twice a day or 3 times a day with meals, now you're just going to take it maybe at iftar and at suhoor, but it's totally okay to take that medication, whether it's Glometza, the slow release, or the regular one. The concern with lactic acidosis on metformin is really a theoretical one in patients with pre-existing very poor GFR. So I don't think that becomes an issue really in Ramadan unless somebody became super dehydrated and just went into acute renal failure, which would be kind of not what we would expect. But generally speaking, metformin is very safe to continue during Ramadan. Next will be DPP-4 inhibitors. So those are all the agents that end in gliptin. Some of the brand names here that people might recognize is Januvia and Tradjenta and so on. Again, those medications work by sensitizing our bodies to insulin and by releasing insulin, but in a fashion that is dependent on glucose intake. So they're actually very safe. And so I usually don't change the doses of these medications. People usually take it once a day, and I tell them just take it with iftar. Again, take it with the largest meal. And if you have a combination medication of metformin with one of those agents, it's completely fine to continue that as well. Next, the alpha glucosidase inhibitors. So those would be medications like acarbose is the only one really that's available in Canada. That one slows down absorption, so it's totally safe to take with iftar and with sahur if your patient wants that. So there's no change necessary because there's no associated risk of hypoglycemia with this class. The TZDs or thiazolidine diones, those ones have fallen out of favor because of concerns about cardiovascular safety, and that happened at least a decade ago. So those are not used a lot, but if they are on board, those are typically safe in Ramadan. Like the fasting is not going to affect them because, again, they are a sensitizer rather than a secretagogue for insulin. Next, we come to Sglt2 inhibitors. Those are the newest kid on the block when it comes to diabetes agents, and they've really taken off in the last few years here because of the renal benefits and the cardiac benefits. So again, with those agents, we have to be a little bit careful because those are kind of like a diuretic. So if you have a patient on a thiazide or a loop diuretic, you would be careful about those because you don't want your patient to get dehydrated, especially in hot, long days and fasting. So these medications I have used in very judiciously during Ramadan. So if somebody, for example, is on a diuretic and an Sglt2 inhibitor, I will tell them they probably should be on one of the two, not both of them. And probably if they're on the diuretic for blood pressure control, I'll tell them to continue that, but maybe stop the Sglt2 inhibitor. It's something that you have to play by ear a little bit. At least I would recommend maybe reducing the dose to 50% or so to start with. And just again, it's a work in progress. For the month of Ramadan, you will find out what works and what doesn't. And the first week is always trial and error. So again, reducing the dose is very reasonable. The main concern, I would say, with those agents is dehydration. And if patients get dehydrated, that's a prerequisite for Euglycemic Dka and complications related to needing admission to hospital. If the patient is vomiting or has diarrhea or is dehydrated, again, the same principle applies. You need to hold these medicines or for a few days until they're better, or you need to cut back on the dose. So this class needs to be addressed. You can't just tell them to take the same dose during Ramadan. Also, if they're on a combination with Metformin, because a lot of Gen Duetto and so on exist, I usually separate them. So for the month of Ramadan, I say take Metformin separately because you're going to take that full dose, but then the Sglt2 inhibitor is a separate pill, and I use a part dose as needed. This is just a slide again about the combination therapy. I prefer to separate the two so I can titrate each one of them as I want to. Next is the GLP-1 agonists, which are again used quite a bit. So those are the agents that are injectable and they end in glutide, like liraglutide and semaglutide and so on. And those ones can be daily or weekly. Those are really useful agents for weight loss. So a lot of people who are overweight will be taking those for the diabetes, but also for weight benefit. And that works really well. And I want to say that I don't think we should be stopping those agents in Ramadan, but I wouldn't start them right before Ramadan. So I wouldn't start it in the month before. If I have a patient who's interested in it, I would say wait until after Ramadan so that we don't have to worry about nausea, vomiting, diarrhea, dehydration, and getting pre-renal with your kidney function and stuff like that. So again, no big changes in the last month before Ramadan is probably a good blanket statement to make, especially with medications that cause dehydration. And the main two agents would be GLP-1 agonists and Sglt2 inhibitors. So again, this one I think can be continued. You might want to consider a dose reduction. It really depends on the specific situation with the patient, but you just need to think about it and warn them about GI side effects. And if they do have those, they need to be more careful and cut back more. Next are secretagogues. So secretagogues imply that those are agents that you take to stimulate your pancreas to make more insulin. Therefore, automatically, those agents are going to cause hypoglycemia. So those ones really need to be modified. There's no way I'm not going to modify this class. No way in Ramadan. We have to modify this class. So the safest one to take is something that is very rapid acting, fast in, fast out. So repaglinide is probably the shortest acting agent in this category. So that one, the safe maximum dose a day is 16 milligrams, 1/6. So what you could do is you can give them as much as you want with iftar being the biggest meal of the day. So for example, if somebody was on a longer acting secretagogue and now you're switching to repaglinide, you can start with, say, depending again on their A1C and how much they're on, you can maybe put them on a bigger dose with iftar, maybe 2 or 3 milligrams, maybe even more. And then a very small dose with sahur, depending on what happens at sahur. If they have a lot of dates and they're very sweet and they have a lot of sugar in them, you might give them more than if they just were going to have some yogurt and water. So again, it's a little bit of a judgment call, but it's easy to titrate. We call repaglinide the Humalog or the Novorapid of oral agents because it's fast in and fast out. So it's very safe. When you think of glimepiride and glyburide, those are very long-acting agents, so we shy away from those in Ramadan because their metabolites last for a very long time. I actually shy away from glyburide in general now, especially in older individuals because of risk of hypoglycemia. Gliclazide is usually very kidney-friendly. Gliclazide MR is a slow-release form, so again, if you do use that, you got to be careful that you're probably going to need to modify the dose, give them less, give it at iftar rather than sahur, and give them less to start with, and see what happens with the sugars. In terms of basal insulin, so using something like Glargine and Levemir and Tresiba, the longer acting ones, are probably safer than using the protamine bound neutral ones. So again, the protamine ones are the intermediate ones like NPH and Humulin N. Those ones peak. So if you give it at iftar, it's probably okay because they're going to be up and eating all night. But if you give it in the morning when they're fasting during the day, that's going to be a problem. So that's why switching to a basal 24-hour or 36-hour insulin might be better, but a dose reduction will be important and necessary. Probably for the longer acting basal ones, the 24-hour ones, you want to decrease the dose by 15 to 30% to start with and see how it goes. Versus with the neutral, the protamine ones, you probably want to reduce it even more because of that peak by 25 to 50%. But then you're running the risk of poor glycemic control, and that's a main concern. And that is where it comes in. Is it safe to really do this? Do we really want to be altering something that's working well? Is it worth it? And that's where the discussion with the patient comes in. Short-acting insulin, again, we have two options. We have the very short-acting. We have, Aspart and Lispro. Those would be the regular ones. There's also Fiasp, which is even faster-acting. Those would all be standard ones to use with iftar and sahur. And then the human regular insulin is probably one that we would not want to use, especially not with sahur. You can use it in iftar, but if you really want fast in, fast out, kind of like repaglinide, like you did in repaglinide, the ones to use probably are the very fast acting ones like Lispro and Aspart, rather than Humulin R and Toronto. I shy away from those, especially in Ramadan. Gestational diabetes poses a unique risk because when you think about it with gestational diabetes, you have really multiple things at play here. So of course you have glycemic control. You want the glycemic control to be good for the mom because this is the lifeline for the baby, is the placenta. If the placenta is clogged up by sugar, that is going to compromise the safety of that baby. So we don't want to do that. So that's why glycemic control is important. But there's other things to think about. For example, maternal health. If the mom is losing weight through her pregnancy, that is not what we want because that would imply that maybe she's not getting everything she needs. Now, don't get me wrong. Sometimes in pregnancy, if a woman will modify her diet significantly after she'd been drinking a lot of pop or eating a lot of sweets and things like that, it is not uncommon to see a period of time where the weight plateaus or even goes down a little bit, but it shouldn't be a sustained weight loss. We're still aiming, of course, for a net weight gain in pregnancy. So again, if it's going to be a situation where for those 4 weeks, the woman is just losing weight, that compromises the baby's safety and also compromises the amount of energy that is making it through to the baby that they're relying on mom for. Especially after in the beginning of second trimester and into the third trimester, the baby is needing a significant amount of energy. And that's why we need to have that intake. If Ramadan falls during the summer when the days are very long and you have 18 or 19 hours of fasting, that's another concern. That's even prolonged fasting for mom and baby. The last point, so the first point was glycemic control and placenta health. The second point was mom's health and weight loss. And then the third point is whether it's safe for baby to be seeing ketones as an alternate fuel for the brain. There's even some healthcare providers that are now promoting keto diet in the setting of pregnancy, and we really don't know that that's safe. There has been some studies in the last 2 decades that have come out suggesting that ketones might be neutral and not harmful for the baby, but there are others that also suggest that they could be actually harmful, not only in the short term, but in the long term when they're in school age and for how their IQ and their brain develops and their cognition and so on. So I think it's an unanswered question. And I think that we need to be very careful to make recommendations to women, even if they're overweight before pregnancy, to say you need to lose weight in pregnancy. That is probably not a sound judgment. So again, I think it's an individual decision. You have to talk, the pregnant woman needs to talk with her diabetes and pregnancy team, with the dietitian. There's a minimum amount of carbohydrates that they need to have in a day that needs to be met. So again, it's an individual decision. So I would like to end with going through a few scenarios and see what we would do for those. Is that okay that I do that? Do we have time for that?
Yeah, we have a lot of time.
Okay.
So you can go ahead. Yeah.
Thank you. So scenario 1 is a 54-year-old man of Arab descent who's had type 2 diabetes for 16 years, and he would like to fast. He has uncontrolled diabetes and really poor diet control and also poor insulin compliance. His hemoglobin A1C is 11.9%, and he has several chronic complications of retinopathy and nephropathy and so on. He's on Lantus 55 units at bedtime and Novorapid 16 units TID and Metformin 500 BID, and he's not very compliant. So what happens here? Well, if you remember, my list of, should not, must not, and can fast, you would say that this fellow might fall into the category of poorly controlled, and therefore that would be an intermediate to high risk, because he's probably running sugars during the day of teens. If his A1C is 11.9, that usually suggests the average sugar is probably around 12 to 15. So this is concerning that if we do allow him to fast, then he might not do well, and he might end up with an osmotic diuresis, dehydration, and then might end up with a complication such as, he's 54, he could have a cardiac event or so on. So again, it is a discussion to have. We would never mandate anything. Remember, it is all in the eye of the beholder. And I can be a very caring physician who wants to do what's best for my patients. But if I have a plan that is not in line with what my patient wants, it's going to fail. So I can have a brilliant plan, but they need to buy into it. So remember that we need to really respect people's wishes. And I'm very aware of that. And as a Muslim physician, people always, say, okay, you will understand, I need to fast. And then I'm like, okay, then I am advocating for you by saying, is it safe for you to fast? So I'm totally hearing you, but is it a safe scenario for you to fast? So looking at this, I would say that my gut feeling would be that this fellow probably is high risk and probably should not fast, assuming his glycemic control at the moment is still in line with this A1C, and he hasn't made any changes in the last few weeks since he had the A1C. Because remember, the A1C, of course, will lag behind by a few months. So if he has fixed things and he shows me a home log that is more compliant and he has actually sugars that are in the single digits, he's doing well, then we can talk about it. So if this fellow now is having good readings, or if his A1C was, say, 8%, then we would go over and say, okay, so your Lantus at bedtime, we're probably going to need to modify that a little bit so that you're cutting back by maybe 10%. So let's cut it back by 5 units or so. And then the Novorapid, we're not going to give you 3 times a day now because you only have 2 meals. We're going to give you the full dose at iftar because that's the big meal of the day. At sahur, what do you eat? If you eat a very, very small amount of food, we might just need a little bit of insulin then. Like we might need 3 or 4 units. But if you eat a big meal, maybe we need 5 or 7 units, but probably not quite 16. 16 is too much for a sahur meal. Probably, typically, but there are some people who eat a lot on sahur. Metformin would be completely safe to continue, and so on. So again, it is a discussion to have, but if this was the A1C and the patient's sugars are 12 to 15, I would say fasting is not safe. I would not tell him you can't fast. I would tell him I don't recommend it. What he does is his business. I just wanted to highlight here, I do teach at the medical school communications. And I think, effective communication is about being an advocate for the patient, not just about doing or mandating what you think needs to be done. Guidelines are guidelines and practice is practice. So when we look at Diabetes Canada guidelines, of course, they're guideline, but they don't know the ins and outs of our patient's scenario. So we really need to embrace that the patient is a person who is living with diabetes. It sucks to have diabetes. It's terrible. There's a constant reminder every day when people have diabetes. So we want to be their advocate. We want to be their ally. So we look at this whole thing as a whole person. Okay, so how does diabetes fall into Ramadan? How can we make this so that you can maybe fast some of Ramadan? And how can we do it safely? So it's, again, building this common ground that establishes and strengthens your relationship with your patient and forms that therapeutic alliance to achieve the goal that the patient feels they need, not necessarily what you think is right. So just a shout out for that, because it's very easy to get caught up and say, no, you can't fast, period. Please have a chat with the patient. Please explain where you're coming from and tell them, what's your goal? Yes. And my goal is also to keep you safe. And therefore you find that common ground. Going to scenario 2, this is a 48-year-old Pakistani man with type 2 diabetes for 2 years, history of high blood pressure, TIA in the remote past, and GERD, admitted with hypoglycemia in 2010, so a long time ago, came to clinic for follow-up with current medications of gliclazide 80 milligrams BID and metformin 500 milligrams BID. His A1C is actually reasonable at 7.4%. He reports he had 2 episodes of symptomatic hypoglycemia during the last month at home. So is it safe for him to fast? So again, let's start with the glycemic control bit. Well, his A1C is 7.4%. So that in itself is not a contraindication. But now let's look at more safety issues and hypoglycemia issues. Well, this is a gentleman who has some chronic macrovascular complications, but they're remote. He does have hypoglycemia though. Even though this was a while ago, he did have 2 episodes of symptomatic hypoglycemia. The good news there is that he's symptomatic, so he's not unaware, meaning he's not going to have a seizure in his sleep, hopefully. So that's a good thing. But the fact that he is having symptomatic hypoglycemia is concerning, because that means his risk of having more hypoglycemia in the upcoming weeks is significant, especially if he fasts. And I want to note here that he is on a secretagogue. And remember, secretagogues were one of those classes we said we need to review those. So I think with this gentleman, I would have again a discussion, and I would say, do you feel strongly that you want to fast because you have a license not to? That's the first thing I would say. And if they say, well, if you think it's better for me not to fast, I would probably feel better not fasting. But I feel ashamed and I feel embarrassed, and I want to do, I want to do my pillar of Islam, and I want to fast. So giving them permission sometimes is our role as physicians, giving a patient permission to say, you know what, you have a license, it's okay. And there's other ways we all know in Islam that you can make up for it. You can feed people, you can donate money and so on. But if he says, no, I really want to fast, then I say, okay, well, listen, you have had some symptomatic hypoglycemia. That makes me very nervous. You're going to have more, especially if you fast. So I think we should probably can the glycoside. What do you think about that? I think we should not use glycoside, and I wonder if metformin is absolutely fine to continue, maybe even increase the dose of that. Consider maybe a DPP-4 agent inhibitor instead of glycoside, but I would completely get rid of glycoside with this symptomatic hypoglycemia. Next would be a 25-year-old woman from Syria. Sorry, there's a typo here. It's a 25-year-old woman, not women, from Syria with gestational diabetes. She is 30 weeks gestation. This is her first pregnancy. She is new to insulin, sorry. She's on NovoRapid 12 units TID with meals and NPH 20 units at bedtime. She is afraid of lows, but she wants to fast. So this happens often, that we have women who, have fasted all their lives and they just don't want to stop now that they're pregnant. Again, it's a discussion to have. She has a license, and that's the first thing I would start with, is you have a license to not fast if you feel that this is too much for you. Depending on how long the day is, when the days of Ramadan fall in the summer, it's very challenging in North America because the days are extremely long. You're fasting for 18 to 19 hours versus in the winter when it's like 4:30, you break your fast. So it's actually a very short day. Before you even get home from work, it's time to eat. So again, it's a discussion to have about all of these aspects. There's cultural aspects. There's all kinds of dynamics at home that I think as physicians, we need to hear about. We need to ask them, how's your husband, your partner feel about this? How does your family? Is the family going to frown upon this, or are they pushing you to not fast? Like, which way are things going? You need to be aware of the whole situation. I think that in this situation, because they're on insulin, probably you would recommend not fasting. But if they feel very strongly and they want to try a few days, I have patients just want to try, and I say, okay, then we need to adjust things a little bit. But again, going over ketone risk to the baby, we don't know that it's safe for the baby, right? Weight loss in pregnancy is not okay. So going through all these things that we talked about, it needs to be an informed decision, but it's not my decision as a doctor. It is the patient's decision as a person, as a Muslim, as a patient, as a mom. And so your job is to give them information and then be there to support them. But again, if you feel that there's a strict danger, you should say no. So in this case, I would tell this patient, probably my inclination would be for you to not fast. That's my best recommendation based on guidelines, based on what I know. And if they still insist, then what you would do here is probably the NPH again, because it peaks. You could continue because it's at bedtime. So it's going to peak at night when she's still allowed to eat and so on. You could continue, but you would cut back the dose a little bit by 10%, maybe by 2 units or so. And then on the TID, obviously, you're not going to give it TID, and you would use NovoRapid rather than R. So that's what you would use. Maybe use the full dose for iftar and a partial dose for sahur again. But my inclination with this patient would be for her not to fast. But again, it all brings us back to this Calgary-Cambridge guide I was telling you about, and how it's not about what I think, it's about what the patient wants, right? And I'm just there to support them, not to make a decision for them. But my job is to make sure they make an informed decision. This next scenario, second last, is a 21-year-old Iranian woman with type 1 diabetes. She has had type 1 diabetes since the age of 4. She has been pregnant for 12 weeks gestation, and she wears an insulin pump. And she checks her blood sugars 6 times a day. She has never fasted before, and she's afraid of lows, but she would like to start this year. In this case, I would say, you know what, if you haven't fasted, this is not the year to start. So, fasting takes some, training of your body, right? We all know that. Anybody who's fasted knows that, you need to really grow up doing it to be able to do it. And if you embrace Islam later on in life, which is wonderful, alhamdulillah, then it takes some time for your body to get used to fasting. So I don't think that starting fasting this year is actually the best idea. So I would really discourage this person. She's type 1. She's in early pregnancy, when the only rule in early pregnancy is there is no rule that the insulin needs can do anything. This is a recipe for disaster. So I would say no in general. Even if she was an experienced faster, I would say no. So let alone somebody who's not fasted before. So this is for me an easy one to just really push her towards that and say, next year, inshallah, you can fast. This was actually my last case. So I hope that we've touched on most of these questions. If we haven't, I am happy to answer that during questions and answers. I just don't want to take up too much time. But I want to thank you very much for your attention. And I'm just going to end with this. This is the sick day medication list that I think is very relevant to kind of fasting. It's not that we're sick when we're fasting, but the mnemonic is SADMANS, and it talks about the medications that you need to think about. And so sulfonylureas would be something that when you're not eating, you don't want to take. So that's one that we want to really visit in Ramadan. ACE inhibitors are good for blood pressure, but they can also cause renal failure. So you don't want to start them in the month before Ramadan. But if they're chronically on it, it's probably safe to continue, but maybe cut back a little bit on the dose if their blood pressure monitoring is suggesting at home that their blood pressure is close to target. Diuretics are something you need to individually consider stopping or cutting back the dose on, because they will cause an a diuresis, and that can be dangerous for renal function. Metformin is safe to continue. ARBs would be the same as ACE inhibitors. NSAIDs are really dangerous if you have already some CKD, because they can cause renal insufficiency as well. So in Ramadan, you want to be careful about taking Advil. It's probably better to take Tylenol and things like that. Sglt2 inhibitors, again, we talked about that and how they really need to be held or halved to avoid Euglycemic Dka and dehydration. And then just to close off, I think education needs to start before Ramadan, and then following Ramadan, don't forget to revisit things again and put them back on their pre-Ramadan state. Some people fast in Shawwal, so make sure that you talk about that too. If they are going to continue to fast the 6 days or even more, then you need to consider going back after they have finished their fasting. So I'm going to end here, and I'm going to stop sharing. So I hope I didn't go over time.
No, we're good. Thank you for filling the gaps in our knowledge regarding fasting and chronic disease management. We have several questions pouring in during your talk. And the first question is, what is the impact of daily fasting for a month in patients who already have chronic kidney disease, and is it reversible?
Yeah, thank you for the question. So if somebody has stage 4 and stage 5 CKD, it is strongly recommended that they don't fast, because remember, then water is your kidney's best friend. So if you get dehydrated, even for relatively short periods of time, that can really compromise your GFR. So you go from a GFR of 15 to 10 very quickly. So probably for stage 4 and 5, I'm pretty sure that the guideline says not to fast. For stage 3, that's probably a GFR between, kind of around 30 or so. You again want to be judicious about it. You're always taking a risk when you don't drink water, when you have kidneys. Like, wet kidneys are happy kidneys. So anytime you abstain from water for any length of time, you are running that risk. Even if it's a hot day and you're sweating, that is compromising your kidneys. So it's a judgment call. Islam is a wonderful religion. It gives us a license. God does not want to torture us. Allah subhanahu wa ta'ala wants us to be healthy. He has given us a license for a reason. We need to use it. So I don't know if that answers your question, but I'm going to say that I really encourage my patients with CKD to not fast.
Definitely. Thank you for the answer. Now we have another question. It says, how is our body's response to intermittent fasting and daily fasting for a whole month?
Yeah, so it's actually a healthy thing. They've done studies on this, and they've shown that there's many metabolic parameters that improve when you fast during Ramadan or intermittent fasting. For people who don't fast Ramadan, there's many in North America who do this for weight loss. In terms of efficacy for weight loss, it's probably as effective as a low carb diet. They've looked at it, it's very comparable. The problem is once you go to not doing it, then you gain that weight back for both of them, for the intermittent fasting and for the low carb diet. In terms of the metabolic benefits, there's a higher HDL, lower LDL, there's better blood pressure, there's better glycemic control. People with pre-diabetes can reverse that and go into a little bit of a remission and so on. So there's definite benefits. Nobody can argue with that. It's just the sustainability of it. And once people usually find that they gain weight after Ramadan because now all of a sudden their body was starving and they put on some weight. So they lose in Ramadan and then they put it on afterwards.
Oh, for sure. I think you kind of answered this next question, but consider it a follow-up. They're saying, is there an evidence of intermittent fasting for helping with weight loss?
Yeah. So again, like I said, it is very comparable to a low carb diet. I'm not going to say keto diet. That's a little bit different, but it is very comparable to that. But again, the benefits are dependent on when you're doing it. Once you stop it, your body usually will be in starvation mode. So it will put weight back on. So I think you need to think about what is sustainable for me, what I can attain and what can I sustain. So not just, can I stop eating for a day and lose weight? Yes, we all can. And our waists will get smaller and so on. But then what's the long-term plan? So think of it as more of a lifestyle change that needs to be incorporated in our day-to-day living, including food, but including physical activity. So they go hand in hand.
Thank you. Now, the next question is, again, regarding fasting, but in some cultures, as you must know, that, they fast, but they consume solids and they can still consume clear fluids and they stay away from solids. So they're asking, how is our body's metabolic response different from that fasting where you're consuming clear fluids compared to, Muslim fasting where we don't consume any fluids at all?
So I guess it depends on what you're thinking about and what you're asking exactly about, right? Like if your goal is to lose weight, then caloric restriction is what you need to do, right? So then if you drink water during the day or drink healthy drinks of some sort, that's fine. And then you're keeping your kidneys healthy. So I guess if that's a rationale to fast from, calories, but maintain your fluid intake to protect your kidneys, that's fine. In Ramadan, it's a spiritual month of fasting and we have to fast a certain way. We don't get a choice of drinking water, but abstaining from solids, right? It doesn't work like that in Ramadan if you want to do the correct fasting for Islam. So again, I'm not sure what the question is exactly getting at, but I think any caloric restriction will be associated with weight loss. The question is, can you sustain that? Most people can do it for a while, but to do it on a long-term basis, it doesn't. So I'm sorry if I'm not answering the question, but those are very hard topics to discuss in 5 minutes.
Sure, yeah. If I understood it correctly, again, I think they're trying to ask, like, people who are consuming fluids, would their weight loss be different from the ones who are, not? So if I understood it right.
Sure. Well, you know what? I mean, you can drink your calories. So be careful because pop has a lot of calories. Juice has a lot of calories. But if you're talking about smoothies that are protein based and so on, they still have calories, right? But they might be healthy calories, like low glycemic index kind of calories. So again, I'm not saying all calories are equal, but you have to be careful that simple sugar, you can only be on a fluid diet and consume a lot of simple sugar in your fluids, right?
Yeah. Okay, so the next question is about teens and PCOS. And the question asks, for PCOS, we encourage certain diet and exercise, but is there anything else you would recommend for people while fasting? What can they do if they have PCOS?
And you're saying, sorry, PCOS, polycystic ovarian syndrome, is that what you said? Yeah. Okay.
Yeah.
So PCOS, we think of it as kind of like it's a condition that's very common. Like 1 in 8 girls will have it. So it's a very, very common condition. It does predispose people to metabolic syndrome. So it can put you at risk for prediabetes and so on because of the ovary just producing too much androgens that make people insulin resistant and so on. So this insulin resistance will predispose people to prediabetes. So fasting will be beneficial. And in PCOS, weight is the cornerstone of how regular periods will be. So for example, if a woman who has PCOS loses some weight, she will notice that her periods will be more likely to come regularly. and fertility will improve. So I would say that my short answer to that question is yes, of course, if you fast and have metabolic, a metabolically good profile in Ramadan, that should help with your fertility and so on, but it's only a month. So it's something, again, you have to sustain for longer than that to see longer term benefits. But I would say that's a good thing. Yeah, fasting is a good thing for PCOS based on what we know today in 2021.
For sure. Now, the next question is, I know that we talked about weight loss with fasting. What other medical benefits can you tell us which are associated with fasting?
Yeah, and so that's what I kind of alluded to earlier. So lower blood pressure, lower LDL and triglycerides, higher HDL. There's probably other things that I'm blanking on, but those would be the kind of the big benefits that I could think of. And that has been shown even since, the days of the prophets, where people have had more favorable metabolic profiles with fasting. It is actually a very healthy thing to fast. If you look up just prophets and fasting, if you just look for fun, Google it, and you will find some interesting things that come up.
For sure. Now, the next question is there any diet or meal plan that you would recommend for sahur or morning meal and the iftar or the evening meal for diabetic patients?
That's such a hard question, Dr. Manef. I don't know if I can answer that. I think that being, smart about your calories is really important. And avoiding empty calories is very important, because I know in Ramadan, depending on your culture, there's a lot of sweets and very high calorie foods that you can consume that are going to fill you up and really maybe cause weight gain and so on. But anyhow, and cause your sugars obviously to go up. So I think that having, if you're going to have carbs, you need to have carbs, have them with your iftar rather than with your sahur. And sahur, probably dates are a really good thing with some yogurt. But I don't want to put this out as like, you have to do this. This is just a recommendation. I think a dietitian would be much better able to answer this question than I can. But if you're going to have your rice or your bread or some kind of some kind of carbohydrate, have it in iftar. A little bit in sahur is probably a good idea, because you're going to go the whole day, especially if it's a long day without. Some people don't even have sahur. I think that's really tough when you have 18-hour days of fasting. That's just so tough. So please eat something, even if it's a piece of fruit. Just have something to eat for sure in sahur. Prophet ﷺ used to eat dates, and I think there's a good reason for that, because we know that dates are an excellent way to get carbs, but also healthy carbs with fiber, and they last you a very long time. The energy lasts you a long time. So I think dates are really good. I'm starting to recommend those more and more now that I grew up with dates, but I don't think I really appreciated dates before. So again, I don't know that is really a good answer, but that's kind of my best answer. I think a dietitian one-on-one, exploring your own culture and what foods you like would be really the appropriate thing to do and the right answer here.
Thank you. There's a question, and I kind of know that you touched it. We get a lot of patients who say we miss our medications and we fast. And so kind of the follow-up question, if you can answer that. I know that a lot of people miss medications and fast, but if somebody has chronic health conditions like high blood pressure or kidney disease or, ischemic heart disease, what are your recommendations for them if they're missing their medications?
Yeah, so the first principle in medicine, but the first principle in Islam is do no harm. So la darara wa la dirar. You don't want to actually hurt your body during Ramadan. That will not be good for you, and it will not make Allah happy. You don't want to fast and then something horrible happens or you have a heart attack. So obviously you need to look after your body. That's your responsibility. And Allah wants us to do that. So I would say that if somebody, say, for example, is on a beta blockers, you can't just stop those. If you stop a beta blocker abruptly, you can get a rebound, high blood pressure and tachycardia, and it can be very dangerous. So you really need to there are some medications you really don't want to miss. So beta blockers would be one of those, and you really need to be careful about that. The blood pressure medications in general are also generally things that you don't want to miss, because if you have a crisis of high blood pressure in fasting, that's not a good thing. If you take too much of them and you have hypotension or low blood pressure, that's also not good. And that's where I think you need to go through your list of medications individually. Aspirin, you need to be taking your aspirin because that's kind of a mild blood thinner. You don't want to have a TIA or something like that during fasting. So not that there's I wouldn't say there's one, those ones you don't have to worry about, but those ones you really have to worry about. I think the general rule is you should abide, you should be compliant. if you don't have the strength or the ability to be compliant, then probably just don't fast, because then you might do more harm by skipping medications without knowing what you're doing. And yes, not all meds are the same, Dr. Munaf, you're right. They're not all the same, but I worry that I don't want people to walk away from this thinking, okay, so the beta blocker is the most important, but nothing else is. I don't want people to walk away like that. So I'd rather them go over it with their family doctor or with their specialist in detail. That's what I do. I go through all of the meds and say, okay, this one will do that with, this one will do that with, and so on.
For sure, thank you. And I know that we can't recommend this, like it has to be a patient-to-patient basis recommendation. So we're just kind of generally discussing these things. There was a similar question with the chronic health conditions if a patient is pregnant. And I think the answer would be the same. Dr. Hanan, what do you say?
Absolutely. Yeah. Pregnancy is very tricky because I know I was pregnant a couple of times in Ramadan, and it's a tough decision to make. You really have to base it on your general health, and you have to weigh the risk and benefit. And if you are on insulin, it's hard to fast. So if you are on insulin, really consider using your license and not fasting. If you're on metformin or just diet controlled, you can try a few days, but remember the risk of the ketones again comes up. We don't know if it's safe for the baby to see ketones for 18, 19 hours. We're not sure. It might be okay, but it might not be okay. And all of us as moms would want to do what's best for our babies. And Allah subhanahu wa ta'ala is Ghafur Rahim. So he's not going to penalize us for using his license. He actually, Rasulullah said, God wants us to use our license. So we make Allah happy when we use his license, and then we are more generous in other ways.
Okay, so I know that we talked a lot about pregnancy, and there's a question that says, what about nursing moms? Can they fast?
Yeah, so nursing moms produce a lot of milk, and that can really be a source of, they can get dehydrated very easily, especially on a hot, long day. So again, play it by ear. You have a license. So breastfeeding is a license to not fast. But if you're in the first 3 months, 4 months, that's when the milk production is really, taking off. If you're at the tail end of your breastfeeding, you might be okay to fast. So it really depends on your situation and what's happening. And also if you have other health conditions. If you're completely healthy, you're at the end of the 2 years of breastfeeding, you probably could fast. But if you're you only delivered 3 months ago and you have other medical conditions, you might not want to fast. Again, license is there, individual decision.
For sure. Now there's another question regarding PCOS and metformin, and are they safe to conceive while they're on metformin?
Very safe to conceive. So that's actually what we expect, people to get more fertile and then conceive. Yeah. So metformin, people think I have shares in metformin. I do not have shares in metformin. Metformin is very safe, and women can conceive on it and stay on it in pregnancy. We actually prescribe it in first trimester and through the pregnancy until delivery and in breastfeeding. So yes, metformin is very safe. It's been around since the 1950s. We haven't seen anything bad. And there's been some trials just in the last few years actually looking specifically randomized controlled, the MIGHTY trial, and it came out saying that there's no risk to the baby. It does cross the placenta, but there's no risk to the baby.
Okay. Another question regarding exercise during fasting.
Mm-hmm. Again, I think
recommendation, like how much and
I think that's common sense again prevails here. If you're somebody who never exercises and you decide to take on exercise and fasting, that's probably not going to go well. If you're somebody who lives on exercising and that's your thing, then you might want to listen to your body and accommodate the fact that you'll not be able to rehydrate yourself if you sweat a lot or if you're exercising on a hot day. So keep those things in mind. You don't want to hurt your body again, your kidneys. If somebody has a solitary kidney or they have some kind of underlying problem, again, you have to be especially wary of that. So, or if you just had a heart attack, God forbid, or something like that. So again, there's all kinds of reasons you should not exercise. But generally speaking, if you're a healthy individual, can you exercise? Yes, you can. But I would take it down a notch. So if you're used to jogging like 10 kilometers, I would say, maybe do 5 kilometers or maybe do 2 kilometers or maybe go for a walk instead. And always the first week of Ramadan is the hardest. The first week of fasting, your body is still getting accustomed. By the 4th week, we all get more resilience in being able to get through our days easier. So just, I would say, in the first week, just don't kill yourself. Don't do exotic things, exercising, but just, listen to your body. And again, if you're going to get dehydrated, that's not good. That's not good for your health. So I would say God would not want you to do that. I don't know if that answers your question, but.
No, it definitely does. Now, there's a follow-up question to that. I've seen a lot of people doing exercise right before sunset, so they know they're going to be eating right. You know, there is a breakfast, fasting, breaking the fast time, sorry. And so do you recommend like any time of the day that's preferable for exercise, or?
That's a great question. And my kids do that, actually. They go for their bike rides and for their soccer, they go because they know they're going to eat and they know we're going to have a big meal. So absolutely. You know, if you don't have diabetes and you're not worried about hypoglycemia, by all means, exercise before iftar. Why not? Absolutely. If you have the energy to do it, for sure. But if you do have diabetes and you have taken insulin and now you're at the tail end, before, like your chances, your sugars are probably going to be the lowest right before iftar. So if you exercise, you're probably going to go low. And then you might need to break your fast sooner because you don't want to be shaking for half an hour, right? And potentially exposing yourself to danger. So if you're not diabetic and you want to exercise, of course you can. But if you are diabetic and you're taking agents that can make you go low, you got to be very careful about that. But I think it's absolutely fine to exercise before iftar, if you're healthy.
For sure. Thank you so much. Now, there's another question. I'm not sure if I understood it correctly, but I'm just going to read it as it is. As an endocrinologist, how safe it is for people to do 20 hours of intermittent fasting on a long-term basis? Is water fasting safe?
Yeah, thank you for that question. I do have a patient who actually does that. She's not Muslim, and she actually does 72 hours of fasting. And I actually tell her, how do you do that? And I tell her, I fast in Ramadan, and 72 hours. She honestly goes without any food. She just does water. And she's managed to lose weight, and she's doing really well and all that stuff. But anyhow, your question is it safe? Again, if you're not pregnant, and you know, we don't think that the high ketones are a danger, then that's fine. Again, you know what? Whatever works for you is my bottom line. Because we used to think, you know, is it safe? Is it not safe? Lots of studies have come out in the last decade, and nothing has really said intermittent fasting is dangerous. We haven't had that study yet. So as long as that's the case and we haven't found that, I would say, if it works for you, that's fine. But if you are on insulin and if you are on agents that will make you go low, or if you're on an Sglt2 inhibitor that will make you go into the Euglycemic Dka, you better be very careful about that. But if you don't belong to one of those categories of insulin treatment, hypoglycemia, predisposed to ketones, then why not? Remember, in pregnancy, women who are pregnant have a higher chance of becoming ketotic because there is such a thing as pregnancy ketosis, because these women are very resistant to insulin due to the placenta and so on. So remember that in starvation you get ketosis, but in pregnancy you get ketosis, and it becomes really difficult to say what is pregnancy related and what is fasting related. And that's a reason why we shy away from, you know, in type 1 diabetes, we don't want people to fast because we don't know what the ketones are being caused by. Same thing in pregnancy. We don't know, is this just pregnancy ketones or is dangerous ketones that are going to send this person to the hospital because they're sick and their baby might be compromised. So again, keep in mind that intermittent long stages of fasting, as long as you're healthy, sure, try it. I don't know if it's sustainable, but if you can do it, all the power be to you.
Thank you so much for answering so many questions. We have tons of questions that are unanswered, and due to time constraint, I don't think we can get to all of those. And thank you to everyone who asked the questions. You have made this session more interactive. Now I would like to share with you another video message from Appna Manitoba team lead, Dr. Mubin Rafe. Dr. Rafe is an associate professor of clinician scientist in the section of pediatric neurology, Department of Pediatric and Child Health at the University of Manitoba. Her clinical and research activity focuses in the field of pediatric stroke and a variety of pediatric neurological disorders. She has published widely in her areas of interest. Can we play Dr. Rafe's message, please?
Good afternoon. I'm Dr. Mubin Rafe, representing Manitoba, the heart of Canada. Manitoba has many other names: the land of 100,000 lakes, the land of opportunities, and the land of great tastes. Most importantly, it has the world's unique museum, the Canadian Museum of Human Rights. We are therefore well positioned to foster a healthy collaborative environment across Canadian provinces and among Pakistani physicians. Our cohesive network will allow us to communicate, innovate, and grow internationally and stay united for a stronger tomorrow.
Thank you, Dr. Rafe. That was a great message. We have a little bit of time before we move on to our second topic of today's discussion. It's a very relevant topic with COVID pandemic, causing extra stress to all of our lives. The anxiety is there. We all want to go out. So this is definitely a great topic that our second speaker will be discussing with all of you. I would like to call upon Dr. Faisal Kosa, who's joining us from Vancouver. I would want him to take over the second half of this program. Over to you, Dr. Kosa.
अस्सलाम वालेकुम एंड थैंक यू सो मच। मेरा नाम फैसल खोसा है और मैं वैंकूवर से आपके साथ मुखातिब हूँ। I have the distinct honor and pleasure to introduce our guest speaker for today, Dr. Sanjeev Chopra. हजरत अली का कौल है कि बड़ा आदमी वो है जिसकी मौजूदगी में और जिसकी महफिल में कोई अपने आप को छोटा, कमतर या हकीर महसूस न करे। Dr. Sanjeev Chopra actually epitomizes this statement of Hazrat Ali during his deanship at Harvard Medical School, the most prestigious and most illustrious institution in the world. Whenever I would meet him, I actually felt as if I was the dean. So Dr. Chopra has influenced and touched the hearts of people all over the world, yet his humility is as awe-inspiring as his influence. So without further ado, I would request Dr. Chopra to come on the stage. Thank you so much.
Thank you so very much, Faisal, for that amazing, kind introduction. I'm truly humbled and honored to be with all of you and share some reflections on a topic that I'm quite passionate about. So I'm going to try and get my slides on the screen. So this talk is entitled Two Most Important Days, Reflection on Happiness and Living with Purpose. I want to make a distinction between terms we often see: happiness, joy, bliss. So happiness is the sensation of feeling good. You're pleased. It's an internal experience in which the goodwill is expressed outwardly, extending the positive feeling towards others. If you're walking down the street and somebody is walking in the opposite direction, perhaps looking at their iPhone and they're smiling, you can tell they're happy. They're having a happy experience. Joy is much more intense and exuberant, but it's much more transient. And bliss I'm defining as the experience of intense joy anchored by a sense of connectedness with others and with nature. It's sometimes been referred to as perfect happiness, unbridled joy. Now, if you and I want to witness bliss, all we have to do is go to a park and see children play. They're on the slide, they're on a swing, they're so happy, they're so much in bliss. And then this 4-year-old tumbles and he bruises his knee and he's crying. And a friend comes over, hugs him. And 30 seconds later, he's back in bliss. Now, all the research has shown that meaningful experiences surpass the acquisition of expensive possessions in creating more longer lasting happiness. So here on the screen, you see a luxury car. Below that happens to be Milford Sound in New Zealand. I've had the good fortune to travel there. It's one of the most scenic spots on this planet. And then on the right part of the screen, you see a huge mansion. And then below that, a charity event. So if you buy a luxury car or move into a huge mansion, you will be happy. But the happiness is most often, in most people, short-lived. After 6 months, 8 months, it's a luxury car, you enjoy driving it. And you live in a big mansion. It's a place, perhaps you entertain friends and family, and you get to sleep there and eat there a lot. but you get used to it. And this phenomenon is called hedonic adaptation. In contrast, meaningful experiences, and we don't have to go to Milford Sound. If I'm in Vancouver and Faisal and I go to a little coffee shop and we're reminiscing and talking about life and ideas, wow, what an amazing and wonderful experience that is. Or if you take part in charity, that will give you much more long-lived happiness. Now, I'd like to ask the audience, how many of you have had a recent vacation? And when I do this for a large group live, a lot of hands go up. Then I say, how many of you have a vacation coming up? And a bunch of hands go up. And I usually say, what's wrong with the rest of you? And that gets a chuckle. But the ones who raise their hands about an upcoming vacation, I say, please raise your hands again. And then I tell the audience to look around and look at their faces. They're all smiling. Just the thought of an upcoming vacation can make you smile, make you happy. And while on vacation, be in the present. Be mindful, enjoy the moment, enjoy the water flowing in the river next to you, or the birds chirping, or the sunrise, the sunset. Don't take 1,600 selfies. Enjoy the moment. And when you come back, your best friends or your family will say, how's that vacation? And as you're reminiscing about it, you'll be happy. So just think about it. Thoughts can make us happy. Now, here's what the research shows with lottery winners. I actually happen to know a guy who lives 5 miles from where we live, and he used to work at Costco. And he would be standing at the door, and when you went with your card, he would look at the card and then he'd sign off and say, you're all set. And together with a colleague at Costco, he bought a scratch ticket. They each paid $4. So for $8, they got a scratch ticket, and they hit it big. They won $20 million, $10 million each. But a bunch of us gave him good advice. And he's invested most of the money. He's actually bought a car for the first time, got a passport, he's traveled internationally, and he's donating 10% of his newfound wealth to a meaningful charity. And when you see him, you can see the happiness and bliss in his face. In contrast, if you don't do that, don't partake of meaningful experiences or contribute a certain amount, it usually is 10%, to a meaningful charity, you won't be happy. Your friends and relatives will come out of the woodwork and say, how did you get so lucky? Pay off my mortgage. And that actually happens. Or they've splurged and acquired and wasted a lot of money, acquired many possessions. And again, as I mentioned earlier, they get used to it, hedonic adaptation. And a lot of research shows that a year later, they're back to baseline, or they're less happy than when they won the $10 million. Now look at the flip side. One of the worst fates to befall a human being. Break your neck and you're paralyzed for life. And that actually happened to Superman. Remember Christopher Reeves, an accomplished equestrian, taking part in a race. Suddenly the horse buckled, he went flying, broke his neck. He's paralyzed. And for the first 2 or 3 months, there's always this victim mentality. Why did God do this to me? I didn't deserve this. But he had an amazing wife, devoted wife, great friends. And here's what he said before a year was over. Human beings are amazingly resilient. He said, I'm not living the life I thought I would lead, but it does have meaning, purpose. There is love. There is joy. There is laughter. Rabindranath Tagore was a very spiritual person, poet. In 1912, he wrote a series of short poems called Gitanjali in his native language, Bengali. And then a year later, 1913, he translated it himself into English. And that year, he won the Nobel Prize in Literature. And Tagore once said, "I slept and dreamt that life was joy. I awoke and saw that life was service. I acted, and behold, service was joy." For those of us who are in the medical profession, a doctor, a nurse, a PA, nurse practitioner, what an amazing profession. Every single day, we can be of service. We can show up in the middle of the night to take care of an emergency, to endoscope a GI bleeder, or see somebody with a massive stroke, or somebody who is getting intubated. It's a real privilege and something that other professions have to some extent. There are many other professions, but something truly unique in our medical profession. Now, Socrates claimed that his wisdom and insights arose merely in knowing that he knew nothing. And prior to him arguing it, it was believed that happiness was bestowed upon a select few. Who were these people? Nobility, the kings, the emperors, the poets, the philosophers. And Socrates said, no, that's not true. It can be begotten by human endeavor. And that happiness and virtue are inextricably linked. The ancient Greeks, in fact, did not use the word happiness. They used a term called eudaimonia, which literally translated means human flourishing. When you're happy, you will succeed. We'll come back to that. So I've come to the conclusion with a lot of reflection, some research, a lot of reading, talking to many of my brilliant colleagues across the country, even in different parts of the world, my family, and even my 2 young granddaughters, the joy of my life, that happy people have 4 traits in common. And the first one is that they have a cadre of good friends. Your friends are your chosen family. I was very fortunate to have the most amazing parents and grandparents and uncles who were amazing, mesmerizing storytellers. And I think my brother Deepak and I benefited from that, and became decent storytellers. Your friends are your chosen family, but your friends you can choose. The best-selling author, James Rohn, he passed away a few years ago, and he once said, "You are the average of the 5 people you spend the most time with." Let me repeat that. You are the average of the 5 people you spend the most time with. Robert Louis Stevenson said, "A friend is a gift you give to yourself." And Khalil Gibran said, "Friendship is a sweet responsibility, never an opportunity." Now, this is the most amazing study. It's the longest standing study on happiness. And it started at Harvard in the year 1938. That was the year Hitler invaded Austria. And then a year later, World War II broke upon us. This study has gone on for almost 80 years. They took about 724 young people, 20, 21 years of age. 275 went to Harvard. The others were from very poor, often dysfunctional families. They didn't even have running water, no heat. And they followed them every year. Detailed questionnaires. Then they started to do physical examinations, blood tests, CRP, cholesterol, blood pressure, imaging, functional MRI, home visits, interviewed the spouses. Who was in this group? There were doctors, lawyers. What happened to them? Accountants, teachers. Some became skid row alcoholic derelicts. 4 ran for the US Senate. 1 became the president of America. John F. Kennedy was in this cohort. Some went up the corporate ladder from the bottom. Others traveled in the opposite direction. What is the conclusion of this study? Just think about it. 80 years. As of a few years ago, 19 was still alive. They were in their 90s. What study goes on for that long? Funding dries out, the researchers die. George Valiant was the third principal investigator, wrote a wonderful book about this, Triumph of Experience. The current principal investigator is a colleague and a bit of a friend, Dr. Robert Waldinger. People drop out of the study. They didn't in this study. Now a cohort of their children, 2,000 of them, are being followed. And the major conclusion of the study is that loneliness is toxic, and that your satisfaction with relationships with friends at age 50 is a better predictor of health, happiness, and longevity 30 years later at age 80. Better than what? Better than your blood pressure, your cholesterol, your CRP, your EKG. So I encourage the medical students and young doctors. I'm privileged to teach both at Beth Israel Deaconess Medical Center and Brigham and Women's Hospital. I encourage them, you may have 15 minutes in the clinic to see your patient, but in the last 30 seconds, ask them what they do to celebrate with friends and point them to this study. A brilliant TED Talk. When you get time, I urge you to watch this TED Talk by Robert Waldinger. It's called What Makes a Good Life? Lessons from the Loggers Study on Happiness. The Harvard Grant Study, the study on adult development. So that's the first attribute of the happiest people on this planet, a cadre of good friends. So choose everything, small or big, to celebrate with your friends. The second trait, happy people have the ability to forgive. If anyone is holding bitterness or rancor or a grudge against an ex, a sibling, a parent, a teacher, a neighbor, I have a plea. Please get rid of it. It's only hurting yourself. It requires a lot of courage. Gandhi once said, forgiveness is the attribute of the strong. The weak can never forgive. The Buddha said, resentment is like holding a hot coal with the intent of hurtling it at somebody who's offended you. That person's moved on. Meanwhile, you're burning your hand. And to me, the most amazing example of forgiveness is that of Nelson Mandela, who spent 27 years in prison. When he's released, he's asked the question, Mr. Mandela, do you harbor resentment against your white captors? He said, I have no resentment. I have no bitterness. Resentment is like drinking poison and then hoping it will kill your enemies. As he walked out the door towards the gate, he said to himself, this is the gate that leads me to my freedom. But I knew if I didn't leave my bitterness and hatred behind, I'd still be in prison, right? The prison of the mind. Now, the third trait I've borrowed from a wonderful quote by Albert Schweitzer. He was a physician, he was a theologian, humanitarian, started a hospital in Gabon, Africa, with his wife, a nurse. And one of the hospitals I work at, where Faisal also trained, Beth Israel Deaconess Medical Center, that hospital in Gabon is a sister hospital. And about 10 years ago, we celebrated the centennial. Schweitzer was a very humble man. When he received the Nobel Peace Prize in 1952, at the ceremony at Oslo, he said, now I have to go earn it. Now I have to go earn it. But he once said, I don't know what your destiny will be, but one thing I'm certain of, the ones amongst you who will be truly happy are those who have sought and found how to serve. So I've distilled the first three tenets for being happy as the 3 Fs: friends, forgiveness, and for others. The fourth one begins with the letter G. and it's gratitude. The word gratitude is derived from the Latin root gratia, meaning grace, graciousness, or gratefulness. Highly prized tenet in Christian, Jewish, Muslim, Hindu, and Buddhist teachings. I'm defining gratitude as the experience of something positive gained, but coupled with the realization that somebody else was responsible for that gain. And I strongly believe that gratitude and compassion can be cultivated. One of the easiest ways is to meditate on a regular basis. Many, many different kinds of meditation. They all have amazing benefits, not a religion. I have a saying, you should meditate once a day. And if you don't have time to do that, you should meditate twice a day. Now, the other way we can increase our happiness and our gratitude is by starting a gratitude journal. So today is Sunday evening. I don't know how many of you have a gratitude journal, but if you don't, I urge you to do it. Buy a notebook, put your name, call it your gratitude journal. Sunday evening, as you're reflecting on what's in store for you in the next 7 days, look back at the last 7 days and write down what you're grateful for. Your happiness quotient will soar to a much higher level. This is based on research, randomized study, and I'll come to that study in a short moment. Now, here's a study. This is called the Catholic Nun Study. This started in the 1930s also. These nuns joined the Notre Dame convent, and the Mother Superior said to them, everyone write down a little piece of paper, page or two, what you're looking forward. Where do you come from? And then 60 years later, the researchers could analyze these statements. They could authenticate it because it was handwritten, not typed. And they classified them into two categories, low gratitude and high gratitude. The first one is an example of low gratitude. I think it's pretty neutral, actually. But if you look at the second one, the past one has been a very happy one. Now I look forward with eager joy to receiving the holy habit of Our Lady and to a life of union with love divine. They're all 23. They live in the same convent. They eat the same food. Nobody is married. As best as we can tell, no one is drinking or smoking. What happened? On average, the nuns who expressed high gratitude lived 10 years longer. Pretty astounding. This was published in the Journal of Personality and Social Psychology almost 20 years ago. Now, here's a ratio that's very close to 3. And unless you're an economist, a good chance you will not know the ratio. This is called the Lasada Ratio, named after Marcial Lasada, an economist. And his research led to this ratio. Negativity is very heavily weighted. If I say something negative to a friend, a colleague, or a student, I now have to say 3 positive things simply to neutralize it. And I'm told if I say something negative to my wife, I have to say 6 positive things to neutralize it. But this ratio has been found to be highly predictive of success, as judged by metrics such as profitability. Here it's shown in a different fashion. And you see whether you study college students, nursing home residents, people in marriages, business teams, leaders, managers, the danger zone is 1. 1 positive expression to 1 negative. But if you're between 3 and 6, you flourish. Interestingly, 11 is also the danger zone. 11 positive statements to 1 negative statement. And I don't know, but I can speculate. Perhaps these are individuals who are manic depressive. They haven't been diagnosed and treated yet. This is a very interesting formula. This is based on the study of monozygotic twins and comparing them with dizygotic twins. What it shows is that 50% of our happiness is genetic. the set point. It's like the thermostat in the room I'm sitting in right now. Only 10% is living conditions. Whether you live in a mansion in Beverly Hills or the shanty towns of Jowtown or a slum in Pakistan or India, if you have a roof and running water, you're very happy. And 40% is voluntary action, what we can do to make others happy, to be of service. Now, even this set point of 50% is fluid and dynamic. And we all know that. If you exercise, you'll be happy. It's as good as the antidepressants in treating mild to moderate depression without any side effects and many other benefits. Behavioral cognitive therapy, meditation, but very importantly, the expression of gratitude. So Robert Emmons is considered one of the fathers of modern positive psychology. He's written a little wonderful paperback called Thanks, How the New Science of Gratitude Can Make You Happier. So he did a large study, randomized. Half the individuals were told at the end of the day, write down 3 or 4 things they did. And the other half were instructed to write down 3 or 4 things they were grateful for. They did that for 6 weeks. At the end of 6 weeks, the people who regularly practiced grateful thinking and wrote it down, that set point went up by an astounding 25%. I've actually shared this with many people, including a family member whom I encouraged to start a gratitude journal and also take vitamin D3. She was deficient in vitamin D3. And you know what? Her life has changed. She's one of the happiest, most caring individuals I know. Look at the power of thanks, how social recognition empowers employees and creates the best place to work. Some years ago, Google took their top managers and took them on an all-paid expense vacation to Costa Rica. Bring your significant other. They were there for 12 days. Food, drinks, bird sanctuaries, coffee, farms, golf. Costa Rica is a beautiful country. It's one of the few countries in the world that does not have a military. Enlightened ruler, Oscar Arias, Nobel laureate. And it cost Google $18,000 per person to pay their expenses. In previous years, they had given these top managers a cash bonus of $50,000. And they were asked, future years, would you like this kind of experience or do you want a cash bonus? And the majority chose the experience. They forged friendships. They met colleagues they had never met face to face, only by email. Again, the social connectedness, the social fabric that brings forth joy. Viktor Frankl, Holocaust survivor, once said, happiness cannot be pursued. It must ensue as the unintended side effect of one's personal dedication to a cause greater than oneself. He wrote a book called Man's Search for Meaning. I don't know how many of you have read it. I urge you to read it. He wrote it in 9 days. I tend to read it every year or so to continue to be inspired. Albert Schweitzer once said, success is not the key to happiness. People think when I get that next promotion, next car, move into a bigger mansion, join a country club, I'll be happy. They'll be happy for a short time. Happiness is the key to success. You'll sleep better, you'll have better interpersonal relationships, you'll flourish. Eudaimonia. Now, I think the modern day philosophers are children. I gave a version of this talk a few years ago at a college, and I share my slides. So by the way, any of you can take these slides, modify them, adapt them, use them. You don't have to give me attribution even. I call it copy left as opposed to copyright. So I give this talk at Assumption College in Massachusetts. And again, I share my slides. And one of the deans writes to me 5 days later. She said, Dr. Chopra, I went over your talk with my husband, but I took your cue. And I asked my 5-year-old daughter, because you said, ask the children. Ask your nieces, nephews, ask your grandchildren, what is happiness? Complete the phrase, happiness is. And she said, my 5-year-old daughter immediately answered, Mommy, happiness is when my heart feels bigger. I had the privilege of giving this at surgical grand rounds at the Beth Israel Deaconess Medical Center. This is a few years ago, a different iteration. The talk keeps evolving. And the residency program director said, Sanjeev, can we meet for coffee? And so we met. And as we sat down, he said, I have a son. He's 2 years and 10 months of age. And I asked him, what makes you happy? He said, Daddy, I'm most happy when I'm sharing my toys with my friends. Now, this is John Lennon, the Beatle. Age 5, he goes to school, and the teacher gives the kids an assignment. Write down what you want to be when you grow up. He writes down happy on the piece of the paper, and he hands it to the teacher. And the teacher says, John, you did not understand the assignment. And he looks up at the teacher and he says, and you don't understand life. 5-year-old. His mother, every night when she tucked him into bed, sang him or told him a bedtime story, would end by saying, John, when you grow up, I want you to be happy. So children are the modern day philosophers, but so are our beloved cartoon and fictional characters. There is so much wisdom. Look at this. Charlie Brown and Snoopy sitting watching the sunset, and Charlie Brown says, we only live once, Snoopy. And Snoopy says, wrong. We only die once. We live every day. Now, this is a game that you can play with your children, grandchildren, nieces, and nephews, and was taught to me by my then 7-year-old granddaughter. She's now 14. The older one is 16. Mira and Anya, they live in New York, and they're visiting with us, come often to Boston, and we're about to have dinner. And she's 7. She says, Nana, before we have dinner, we're going to play a quick game. I said, okay, Mira, what's it called? She said, it's called Thorns, Buds, and Roses. I said, I don't understand. She said, I'll explain. My thorn for today is my cousin was coming for a play date, but her father got very busy and couldn't bring her. Negative. My bud is she's coming tomorrow. And my roses are, you took us this morning for breakfast, then you took us to Barnes & Nobles, you got me 3 books, and Nana, after dinner, you're going to tell some amazing stories. You're a pretty good storyteller. Now, you go around the room. You start with the youngest and you finish with the oldest person at the dining table. It takes a few minutes. Everybody is happy. And look at what Mira did. She had 3 times as many roses as the one thorn. A very simple thing we can do to be happy. Look at this. I was interviewed by BBC. They said, Dr. Chopra, you're sort of a professor at Harvard Medical School and you're a dean, and you quote Winnie the Pooh? I said, again, there's so much wisdom. I'd written a book, and so they were interviewing me. And Winnie the Pig says to Piglet, if you live to be 100, I want to live to be 100 minus 1 day, so I never have to live without you. What sublime friendship and love. Now, amongst the happiest countries in the world are Denmark, Finland, Norway, Iceland, Australia, Austria, Costa Rica, Singapore, Switzerland, Sweden, Canada. You guys in Canada, amongst the happiest countries. And many years it used to be Denmark. You also see on that list Bhutan. Bhutan is a small country, as you know, in the foothills of the Himalayas. 35 years ago, the ruler said, we are going to care more about gross happiness product, more so than gross domestic product. They have a ministry of happiness. They track everyone's happiness level every year. Now, it's a small country, it's very doable. America is usually 22nd, the most richest, powerful country in the world, not as happy. Now, what's unique about Denmark? They work 35 hours a week. They have national health care, free education. They also partake in a very interesting social phenomenon, which I think we did back home in India and in Pakistan. Somebody would just knock on the door. They didn't call you, and you'd open the door and see a friend and you'd welcome them and you'd sit and have tea or coffee and talk about life. And this phenomenon is called hygge. Hygge is also practiced in Norway. It's the informal gathering of friends. If I'm in the neighborhood of Faisal's home, I don't pick up the phone and say, Faisal, are you home? Can I drop by? I simply ring the doorbell. And if he's at home, he says, Sanjeev, come on in. And you sit by the fireplace if it's winter and you have hot chocolate and you talk about life. Cozy, comfortable, convivial. But Denmark has another very unique thing, which I only found out a few years ago. And that is that between the ages of 6 and 16, when children go to school, every week, once a week for 1 hour, there's a mandatory class, interactive. What's the topic? Empathy and compassion. They learn to be more tolerant. Something that I think every school, everywhere in the world should incorporate. And they started this many years ago. I was in Denmark 2 years ago, amazing country. But a few months after I left, they started the first World Museum of Happiness. So they have a museum on happiness. Now, those 4 things I mentioned earlier, friends, forgiveness for others, and gratitude will make you very happy, right? Low tech. We don't have to spend a fortune to be happy. But happiness is more than the sum total of happy moments. And in order for us to have sustained happiness, to be happiness most of the time, we have to find our purpose and live it. Mark Twain once most famously said, the 2 most important days in your life are the day you're born and the day you find out why. Each one of us has a singular purpose in life. My latest book is called The 2 Most Important Days, How to Find Your Purpose and Live a Happy and Healthier Life. Wrote it with a friend, and she was one of the deans at Harvard Medical School, Gina Wild, Associate Dean for External Communications, a good family friend. And before we published it, we looked and there were like 25,000 books on happiness, with the title Happiness in the book, on the book. So we chose this title. And now when you open the book, you see this quote. Now, defining your purpose can come by reflecting on it or by virtue of a key moment in your life. And often that key moment is very negative, stark, horrific. But the person experiencing it, if they have the fortitude, the grit, the compassion, the love to say this is unacceptable, I'm going to try and make a difference here. And they start. And many, many times, they're still doing it 40, 50 years later. It's become their purpose in life. And if you meet these people, you can see the bliss in their eyes. If you read about them, you see a photograph of them. You can tell they're the happiest people on this planet. Most of us will experience sorrow. When you experience the abyss of sorrow and emerge stronger and with a clear purpose, you will have triumphed. Even in concentration camps, Viktor Frankl talks about it. He said, we who lived in concentration camps can remember the men who walked through the huts, comforting others, giving away their last piece of bread. They may have been few in number, but they offer sufficient proof that everything can be taken from a man. But one thing, the last of the human freedoms, to choose one's attitude in any given set of circumstances, to choose one's own way. The Buddha once said, every life has a measure of sorrow. Sometimes it is this that awakens us. Now, I'm very privileged and fortunate to have met this individual you see on the screen about 12 years ago at a leadership course at the Kellogg School of Management in Illinois. He's from the country Colombia. His name is Jaime Aramillo, but he's a national hero. hence the name Papa Jaime. He's 70 years of age now. When he was 28 years of age, he's standing at a street corner in Bogota, and across the street, there's a sewer. There's an underground city there. These orphans live there. And he's looking at the sewer, and this 7-year-old girl, beautiful girl, emerges. She's smiling at him. And he's saying to himself, I got to do something to help these kids. As they're having this interaction, a car comes around the corner, stops in the middle of the street, a window rolls down, somebody tosses a toy. It's a yellow school bus, Fisher-Price toy, and the car recedes. This 7-year-old girl has never possessed a toy. She comes running to the middle of the street, picks up the toy. She's looking at Jaime Aramillo and beaming with joy. And as they're having this interaction, the speeding truck comes around the corner and smashes her into oblivion. And he says to himself, this is it. This is my calling in life. I'm going to adopt these kids. He has adopted, housed, schooled, and fed 52,000 orphans. National hero. Hence the term Papa Jaime. So I said to him, I said, Papa, how many staff do you have? How do you pay for all of this? He said, Sanjeev, I have a staff of 150. I have a bakery. The only thing we make is cookies. I've convinced all the restaurants in Medellin, Bogota to have a cookie jar. So people leave the restaurant, they grab a cookie, there's a shoebox in the slit, they drop change, $1. I get 50% of my needs that way. I said, wow. I said, what about the other 50%? He said, I'm a motivational speaker. I speak all over Latin America and I plow my honorarium into my foundation. So I said, Papa, come on, that doesn't cut it. I know what motivational speakers get. So he smiles, he says, you're right. You know, every time I need money out of the blue, somebody helps me. He says, 3 weeks ago, I needed $41,000 to pay my bills. So I go to 3 banks and they turn me down. I said, Papa, you already got loans with us at the lowest rate. Don't even tell anyone. We love the work you do, but we can't give you more loans. So he's coming back to the office and there's a street woman across the street. She says, Papa Jaime, crosses the street and gives him a hug. And he turns to her and he says, are you hungry? She nods. He says, come to the office. So she's sitting in his office having coffee and cookies, and he's on the phone calling 3 other bankers. And she can tell that he's being turned down. So he says, Sanjeev, she looks at me and says, Papa, how much money do you need? So I said, I need $41,000. And she looks at him, smiles and says, I give it to you. He said, Sanjeev, I said to myself, she's cuckoo, the street woman. How can she have that much money? She opened her purse. She had $60,000. Her son had sent her the money. She had to go to a bank, sign a piece of paper, move into a home. She says, I've saved some other money. I'm okay on the street right now. The weather's good. You need it. Your children need it. Take it now. No questions asked. You can return it if you want, when you want. So that kind of thing happens to me all the time. He then showed me the photograph of a young lady with 3rd-degree burns on the entire left side of her body. One of his new orphans. They instructed not to leave the orphanage, not to go begging, but this young lady, young girl, was begging outside a fancy restaurant. The restaurant owner called the police. It was not the police, but a death squad that showed up, put her in the gutter and torched her. 3rd-degree burns, entire left side of her body. He rescued her. She underwent 17 reconstructive surgeries, went to school, came to the United States on a scholarship, computer sciences, back home, married. He told me the story 10 years ago. That time he said, she has a 3-year-old daughter. That 3-year-old is my grandchild, plays with my biological grandchildren. The next minute, he showed me the photograph of a young man, handsome young guy, dressed in impeccable white with a tennis racket in his hand, flanked by Pete Sampras on one side and Agassi on the other. Junior national champion of Colombia, tennis. His kids have grown up to become doctors, nurses, computer scientists, professional athletes, doctors, surgeons, and many of them are giving back to the foundation. But he found his purpose in life 40-some years ago, 42 years ago, witnessing the tragic death of that 7-year-old beautiful girl. Joseph Campbell, a very spiritual person in the 1980s, there was a series on PBS with Bill Moyers interviewing Joseph Campbell, whole series. Very spiritual, he knew all the religions, and he traveled. He wrote a book called The Power of Myth, A Hero's Journey. And he once said, follow your bliss. Doors will open where there were no doors before. Now, here's a remarkable individual by the name of Jose Abreu. He's from the country Venezuela. And about 35, an economist, he died a couple of years ago. And on a lark, he took 9 kids off the street, poor kids, taught them classical music. There are now 400,000 children in Venezuela playing classical music. A few years ago, 2 people at the commencement at Harvard got an honorary degree. It was Abreu and Oprah Winfrey. I don't know if this video will show.
Start the year smiling at Aspen Dental with our biggest savings of the season. Right now during the Everyday Smiles event, save not 20%, but 30% off.
Okay, I think it might. Wonderful.
Last year at the proms, here in the Royal Albert Hall, something amazing happened. A huge orchestra of kids from the shanty towns of Venezuela came to play Shostakovich's 10th Symphony. One critic called it the performance of the season so far. It was an astonishing proms debut for one of the most remarkable orchestras in the world.
I would say in my experience that there is no more important work being done in music now than is being identity as I can do this.
No child is excluded. Children with special needs or who are blind or deaf all experience the transformative power of music.
So here on the screen, you see this conductor. This is Gustavo Dudamel. He's a product of El Sistema, which stands for the system. I mentioned 400,000 children learned classical music. 90% would be in gangs, on drugs, some would be dead. Now they're performing in Vienna. The critics are calling it the performance of the year. Gustavo Dudamel, at age 27, became the conductor of the LA Philharmonic. He's one of the most celebrated conductors in the world. There's a similar program now in LA, in Boston, in Sweden, in Scotland, in Greece, and many other countries. Abreu found his purpose in life with a little experiment he did. Teaching 9 kids off the street classical music. Now, here are 5 things you see on the screen. I should have said I love you more often. I should have had the courage to pursue my dreams and aspirations. I should have traveled more. I should have been the bigger person and said, I'm sorry. I should have spent more time with my friends. Who are these people? You all know it. These are people in hospice, facing imminent death. When asked, this was a nurse who asked about 1,000 such people, what are your greatest regrets in life? Nobody said, I should have worked harder, should have driven a more fancy car, lived in a bigger mansion, belonged to 3 country clubs. So the point of this is, we all need to be doing this now. Let not any of us have any of these regrets on our deathbed. It's tough to travel right now. It will open up slowly. But you can travel locally. Even during COVID, I would meet one of my best friends outside a coffee shop, and we'd sit in our cars in the parking lot, 8 feet apart, roll down the window, and talk about life. Now, here's a young lady. She's now 18 years of age. and her name is Greta Thunberg. And she's a political activist seeking to stop global warming and climate change. She's spoken all over the world, many different fora, met many presidents and chancellors, prime ministers of different countries. She came to the UN. She didn't want to fly and create a carbon footprint. Came in a boat that took about 2.5 weeks. No carbon footprint. Amazing young lady. And she once said, adults keep saying we owe it to the young people to give them hope. But I don't want your hope. I don't want you to be hopeful. I want you to panic. I want you to feel the fear I feel every day. I want you to act. I want you to act as you would in a crisis. I want you to act as if the house is on fire, because it is. Forbes magazine had this cover story a while back. And there have been some, hitches, especially in Germany. But if you look at these leaders from these 7 countries, you'll notice that they're all women. Women tend to be much more nurturing, much more team players. There's a wonderful book by Helen Fisher, an anthropologist from Yale, that I read about 20 years ago. It's called The First Sex, The Natural Talents of Women and How They're Changing the World. Here's another remarkable person who's become a friend, very inspirational. Jennifer Staple. She was a pre-med student at age 19, did an ophthalmology elective at New Haven, saddened to see people who'd grown blind from treatable, preventable causes of blindness. Who are these people? Poor people. West Haven, New Haven, never saw a doctor, too late. So she goes back and with 19 other students forms a foundation called Unite for Sight. She now has 4,000 volunteers. They are medical students, nursing students, professors of ophthalmology, web designers. She does a global health and innovation conference at Yale every year. People come from 50 countries, about 2,000 people, 50 talks, several keynotes. I've been privileged to speak there. She got admission to Stanford Medical School, and she wrote to the Dean of Admissions and said, I need to continue on my foundation, which she had started, continue to work 80 hours a week. Can I defer? And the dean said, Jennifer, take your time. When you're ready, we'll be ready for you. In the last 16 years or so, they have performed 92,000 sight restoring surgeries. They have seen 1.5 million patients. They collaborate with other eye institutes all over the world, including the Arvind Eye Institute in India. Here's another remarkable young man, Adam Braun. He's a student at Brown, does a semester at sea, and on a lark, every country he goes to in Africa and Asia, he picks an 8-year-old kid off the street and says, if you could have one wish in the world, what would it be? This 8-year-old girl in one of the African countries says to dance. He says to the interpreter, ask again. I don't think she understood the question. She repeats it. Another country, 8-year-old girl, for my mother to be healthy, hold my hand and walk me to school. He goes to India. He meets an 8-year-old beggar. Same question. And this 8-year-old beggar boy says, a pencil. He goes, what? Pencil? You can have any wish in the world. The boy begs outside a school. These kids come out of the school, sit on a wall next to him, open their notebooks. They have a pencil and they're drawing and they're writing and they're happy. They're laughing. He thinks his ticket to happiness is having a pencil. So Adam buys a whole bunch of pencils. Every country he goes to, he doles out pencils to kids on the street. He comes back to New York. He's haunted by the image of this 8-year-old beggar boy. All he wanted was a pencil. So he starts a foundation called Promise of a Pencil with $25, does a fundraiser. He's now built 200 schools across Africa, Asia, and Latin America. Forbes magazine has rated him one of the most influential people in the world. under the age of 30. He's invited to a rooftop in Manhattan. And most of the people are white men, and they're older. He's this 26-year-old kid. And an elderly gentleman walks over to him and says, "What kind of work do you do, young man?" He says, "I work for a nonprofit," and the guy thumbs his nose and walks away. So as he's walking away, he says, Sir, can I have your email?" So the guy gives him his email. Adam writes to him 2 days later and says, "Can you spare me 30 minutes? Have a cup of coffee with me." So the guy agrees. They sit down. And when he sits down, he says to him, "I don't work for a nonprofit. I work for a for-purpose organization." See, the word nonprofit has a negative connotation. What's the CEO making? $1.2 million, going on golf junkets? For purpose. He says, "We build schools for the poor kids in the world." And the guy takes out his checkbook and writes him a check for $20,000. He needs about $40,000 to build a school, those parts of the world. Now, many, if not all of you, will recognize this absolutely amazing, inspirational humanitarian. When I first showed this slide to my wife, and Faisal, you've met Amita, she looked and she said, "You can see he's a saint." And there's no question, he probably was one of the happiest persons on this planet. The number of lives he touched, absolutely amazing. Pakistani philanthropist, ascetic, humanitarian, founded the Eidi Foundation, runs the world's largest volunteer ambulance network, 1,800 ambulances, but also homeless shelters, animal shelters, rehab centers, orphanages. Eidi was registered as a parent or guardian of 20,000 adopted children. He is known as the Angel of Mercy. The Huffington Post claimed he might well be the world's greatest living humanitarian. A few years ago, he was nominated for the Nobel Peace Prize. I think that's a pretty political thing, so he didn't get it, but he also received many, many awards, including the Gandhi Peace Award. Now, many of the stories I've shared with you are daunting. The Jennifer Staples, Papa Jaime's, Eidi. We don't have to do that. We can start small. And if you change one person's life, there can be a ripple effect through generations. It's a wonderful starfish parable. For a young girl walking on the beach, there are 10,000 starfish stranded. So she picks one, twirls it, throws it into the ocean, picks another one. There's an old man sitting on a rocking chair, smoking a pipe, reading a book. He says, young lady, come here." So she goes over. He says, "See this beach? There are 10,000 starfish stranded here. Look across. There's another beach. There are 15,000 starfish stranded. Do you think you're making a difference?" So she picks a starfish, twirls it, throws it into the water. Starfish starts swimming. She looks at the old man, says, "It made a difference to that one. So we can all make a difference." I'll conclude by sharing with you my purpose in life is to fulfill my dharma, Sanskrit word which distills within it vocation, moral compass, authenticity, truth, to teach medicine, to teach about leadership, teach about happiness, to do it grounded in humility and with an ardent desire to learn every single day, to express gratitude to my family, friends, colleagues, students, and patients who inspire me in countless ways, and in some small measure, inspire everyone I meet on this amazing life journey. I invite you to reflect on what gives you the greatest joy and resonates for you. Take a few minutes now or later. You may have already written down or thought about your purpose in life. If not, reflect, it will come to you. Write it down. Share it if you wish with your closest family members and your chosen family. It is my fervent hope that you will have found your purpose, or you will find it, and that living it will give you lasting happiness and will light up every single day of your life. Thank you so very much for sharing this time with me.
Dr. Chopra, we are extremely grateful. There are a lot of questions, but unfortunately, we'll have to take them another time. One comment I would like to share with the audience that Dr. Chopra does not believe in magic. So, जादू ये नहीं मानते. तो एक दफा इन्होंने मुझे कहा, अमिता भाभी भी थी, तो इन्होंने कहा explain जादू. तो मैंने इनको कहा जादू वो है जो आपके अल्फाज लोगों पर कर देते हैं. That day he understood. He still doesn't believe in magic, but he at least understood what magic is. So, thank you so much, and we are very appreciative of your time. And
Faisal, I'll just say one thing. If there are questions, you can send them to me and I'll respond by email and then you can share them.
Absolutely. We'll do that. Thank you so much. God bless. Thank you.
All right. Thank you, everyone. All the best.
Thank you so much, Dr. Chopra. I'll definitely work on my gratitude journal, and I encourage everybody to work on theirs. This was a much needed talk during the COVID pandemic. Now I would like to share a video message from our Appna BC team lead, Dr. Barbara Rana. Dr. Rana is an adult psychiatrist with Vancouver Mental Health and Burnaby Psychiatrist Services. She has been the CME coordinator for Burnaby Psychiatrist Services for the last 20 years. She is the president of Pakistani Canadian Women's Society and Professionals Beyond Borders. She has received multiple awards, including Gold Medal from Senate of Canada for Community Services. Let's hear from Dr. Rana.
My name is Barbara Rana. I'm a consultant psychiatrist. I represent the multicultural, diverse, beautiful, vibrant province of British Columbia. I'm a very proud member of Appna. The goal of Appna is to ensure and promote evidence-based medical education and scientific research for the physicians of North America, especially for the new medical graduates. Our continuing medical education events will enable our physicians to make knowledgeable decisions for their family, for their patients, families, and the community at large.
Thank you, Dr. Barbara. We are almost at the end of our session, but before we wrap up, I would like to invite Dr. Amir Aslam to please say a few words. Dr. Aslam is a family physician in Calgary. He's a proud member and certificant of Royal College of Physicians UK, Royal College of General Practitioner UK, and College of Family Physicians of Canada. He has keen interest in teaching medical students and residents. He's currently affiliated as Assistant Clinical Professor at University of Calgary. Welcome, Dr. Aslam.
Oh, thank you so much for your nice introduction, Dr. Tamina Munaf. Being as a lifetime member of Appna, it is my pleasure and gratitude to congratulate Appna Alberta chapter to organize this excellent, informative webinar today. I would like to thank all the audience who joined us and make this program successful event. I hope you enjoyed this session, and I hope you will join more programs in future. And I would like to thank our distinguished speakers, Dr. Hannah Bassioni and Dr. Sanjeev Chopra, who have taken time out from their busy schedule and joined us and presented excellent evidence-based talk and make this seminar very meaningful and informative. So thank you. I would like to express my deepest gratitude to Consulate General Mr. Jambaz Khan for his presence in our seminar. And I would like to express my thanks to our Western provincial leads, Dr. Barbara Rana, Appna Alberta lead from BC, Dr. Najma Jamil, Appna Saskatchewan lead, and Dr. Mubin Rafi, from Manitoba Lead for their participation in this seminar. And I would like to take this opportunity to thank all the Appna members, Appna Alberta executive team, Appna team members in program committee, technical committee, and Appna Alberta leadership, who tirelessly worked hard voluntarily to bring this seminar a successful event. So thank you. And I would like to thank our sponsor, Canada Diagnostics, who financially supported this program. So thank you for your support. Lastly, I would like to thank Dr. Tamina Munaf and Dr. Faisal Khosa for their excellent hosting of this event. Thank you. Back to you, Dr. Tamina.
Thank you so much, Dr. Ahmed. Those are really kind words from you. We had a very educational and informative session, and we have accomplished so much in a couple of hours. I would like to thank you again, CDC, for sponsoring our event. Thank you so much, everyone, for listening in and joining us today. We would not hold you any longer over the weekend. This concludes our session today. Have a great rest of your day.